Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Tel Luca.
Welcome to the Thinking Practitioner.
Books of Discovery has been a part of massage therapy education for over 20 years. Thousands of schools around the world teach with their textbooks, e-textbooks, and digital resources. Books of Discovery likes to say, learning adventures start here. They see this same spirit here on the Thinking Practitioner Podcast. And they're proud to support our work, knowing we share their mission of bringing the massage and bodywork community enlivening content that advances our profession.
So check out their collection of e-textbooks and digital learning resources for pathology, kinesiology, anatomy, and physiology at booksofdiscovery.com, where Thinking Practitioner listeners can save 15% by entering Thinking at checkout. So Till, how are you today?
Doing very well. Whitney, how about yourself?
I'm doing very well. We have a special guest joining us again today. And who is our guest today?
Oh, well, our guest, welcome, Dr. Tina Wang. I'm so glad you could take the time to join us.
Yeah, thank you for having me. I'm excited to be here.
I'll go ahead and introduce you, but then I want to hear a little more about you and your work. You are a board-certified physical medicine and rehabilitation medical doctor with a special focus in the emerging field of fascia, which is how I came across your work. I saw you present at the Fascial Research Congress in Montreal. You are an assistant professor at medical schools in Southern California, and you're on the core faculty for the musculoskeletal curriculum, including the use of ultrasound-based diagnosis and interventions. Your published research focuses on ultrasound characteristics of fascial dysfunction to improve clinical understanding, diagnostics, and treatments of myofascial pain syndromes, Ehlers-Danlos syndromes, and hypermobility spectrum disorders. Very interesting. You have a private practice. Doesn't stop there. You have a private practice where you see people with HEDS, or the hypermobility version of Ehlers-Danlos syndrome. And you're the founder of The Brain Cell, a startup dedicated to evidence-based neurofascial inflammation education for professionals. Wow. It's great to have you here. Anything else you want people to know about you and your work before we get into it?
Yeah, absolutely. It's been a journey working with hypermobile Ehlers-Danlos, the population, and I've learned a lot about myself as well as fascia working with this population. It's been not a boring day goes by. Very interesting group to work with.
Very interesting group, very interesting condition, and some interesting quandaries. I mean, I'm sorry to interrupt you, but I got interested in talking to you about all this and your work because it's a puzzle. You know, people with hypermobility syndromes tend to be more flexible in their tissues, and yet they often have more pain. And that is counterintuitive for a lot of people who were trained in a soft tissue approach that emphasizes relaxing or mobility. I think, okay, so if they're relaxing more, what do they hurt more? So I hope we get to that. But sorry, back to you, back to your own journey and your own interest there.
Yeah, that is one of the conundrums that led me to conduct my research, because I would say clinically, I'm not seeing that. Clinically, yes, they can bend over, touch the floor, bend their elbows back over 10 degrees in hyperextension, but the tissue is not moving. And passive tissue stiffness is not consistent with what I would see in someone who's very, very glidey, mobile. And just to add to that, 30%, 25 to 30% of the population has generalized hypermobility. And when you touch their tissue, feels great, feels normal. I wouldn't even think to go checking. And it's oftentimes that I go checking because they say, well, so-and-so in my family has hypermobile EDS. Can you check me? I'm super bendy. And under ultrasound examination, when it's not pathologic, when it's just a phenotypic expression, it just occurs naturally in the environment and there's no pathology, the tissue looks great under ultrasound. Tissue feels great when you're treating the client or the patient.
It feels great to our hands as manual therapy practitioners. Yeah.
Yeah. And yeah. Like any other tissue would.
Yeah.
Can you tell us a little bit about what you would see or what do you perceive on ultrasound as the distinction between those individuals with the different tissue types? How does it look different?
And I'm sorry, can I back up one step? Can we just, for our audience, say what EDS is or what
that's a good idea.
HADS is?
Yeah.
Should we start there? And then let's dive into that question.
Yeah.
How do you answer that question, Dr. Wang?
So there are 13 different subtypes based on the 2017 nosological classification. So that's how we classify what type of connective tissue Ehlers-Danlos you have. And of those 12, we have known genetic variants, and they're really rare. And they run in families, and we do genetic testing. And on physical examination, there are very, very clear signs that show up. And those, some of those are very, very worrisome. And that's what we're really, as clinicians, thinking about when we're screening these patients. We don't want to miss some of these subtypes. And then the 13th subtype, which is the overwhelmingly most common one, is the hypermobile type. And that diagnosis is not based off of genetic testing. It's based off a clinical diagnosis. And there are 3 parts to that diagnosis. The first part is, are you generally hypermobile? So that's part A. And again, we had already said 30% of the population is generally hypermobile without issues. So I've seen that occur where, and can you imagine that? That's 30% of the population. So if you're labeling 30% of the population with hypermobile EDS, that's huge. Issue. Yeah.
Well, and so what is the definition in that case of hypermobile? How are we describing that? It's not symptomatic, you're saying?
Yeah, there's a Beighton score that we use. So there's a cutoff based on age and gender assigned at birth. Yeah. And so then if you do meet that criteria, we have to move on to B and C.
Give me a sense of what the criteria are. Is it the gross amount of movement? Is it how do you determining this 30% are hypermobile but asymptomatic?
Right. So that B part is what then is manifesting in the tissue. So systemic manifestations. What's the shape of the jaw? What are the heart valves doing? How long is that arm? How long are those spindly fingers? And you can't tell. So when I first started doing this, I never even thought that I had hypermobile type EDS. And you can't quite tell. I always thought I had short, stubby fingers, but you need to do measurements. So part of that is we do measurements to be more precise.
Okay, I'm learning something already. And I'm pulling up this file in my own memory, but I don't want to presume anything. There are different proportions to different body parts in this group we're calling hypermobile EDS. And one of them is the longer fingers, and there's some other ones as well.
Yeah, and long arms. So you wouldn't be able to tell. You have to measure. And I never thought I had long arms relative to my height.
So let me also backtrack for just a second. When we said, if I was hearing correctly, 30% of the population has hypermobile EDS. Is that correct?
So no. 30% of the population has asymptomatic general hypermobility. It is
so we're just talking about a generalized hypermobility at 30%. Okay,
right.
That's what I was missing, because I was going to ask, well, what was the population that just has hypermobility that may not have the EDS presentation?
Yeah,
so
and
30% is the across the board. Okay, got it.
Yeah, and a very small percent, and it looks like it's maybe about, it depends on who's estimating and which study, but it can be as few as 0.2% to as high as 4.5%. And so you really can't tell by looking at someone if they have that, because I hear that a lot. Oh, I'll walk around and now I can see they have. And well, there's a lot of variables to meet the criteria. And
shape or proportion is just one of them.
Right. And listening to the heart, the echocardiogram, heart valves, looking at how stretchy the tissue is. So we want it to be stretchy, but not pulling off, because once it's too hyperextensible, then
Mhm.
we're really suspecting a genetic form or other cutaneous manifestations of pathology that may be, not related to Ehlers-Danlos if it's in a localized area. So then our diagnostic framework starts to widen based on if the tissue is way too stretchy, and we check on the neck and on the wrist, and then the one of the most common ones, almost across the board, every single patient that I see has, are piezogenic papules. So you have them stand, and out of the connective tissue, the fascia of the heel, the fat herniates out, and you'll feel the little papules.
Of the heel, the
Mhm.
fat pad on the heel. Okay.
Right. And so the last part of the diagnostic framework then is the most difficult. And that one's the exclusionary diagnosis. And that's really looking at forms of neuromuscular conditions that can mimic or co-occur with hypermobile Ehlers-Danlos. And that one is challenging. Part of my background is extensive neuromuscular training. So even though I'm not subspecialized in it, I've worked long enough in neuromuscular medicine, trained underneath neuromuscular medicine physicians. And then now I have the privilege of working with them, that I can identify. I may not know what to do, but I can say there is something we're missing here and we need additional workup. And that I have a very low threshold for. So I'm not so much interested in it. If you have hypermobile EDS, great. But I am worried if we're going straight to that and we're missing some other diagnoses that needs extensive workup. And that's where I'm really thinking, what I'm thinking about when a patient comes in is, let's make sure we're not missing anything.
And so you've given us a really clear and detailed answer about diagnostic criteria and this process you go through as a physician. Now, as a massage therapist, say, what would be important for them to know at this point? What would they be? What were some red flags or things to begin to suspect this kind of condition?
Well, I have a twofold answer to that. My referrals from massage therapists have almost always been spot on. So you get referrals from physios, from other medical doctors, from whomever, specialists. And when they come from massage therapists, they're almost always like, yep, you have Ehlers-Danlos. And what it is the tissue quality. It feels like a non-scientific term, mush. And it's this uniform, spongy mush. You feel like there's going to be liquid that comes out of them when you palpate. That is almost always there. Not all the time. Some of my patients are very, very thin. And so, yes, it's there, but it makes palpation a little bit more challenging because there's such little tissue to palpate through. Mm-hmm. But that would be really one of the, when I receive referrals from massage therapists, that's what they're feeling. And they're feeling this lack of glide in there too. Just something is not quite right.
Okay, so that's the paradox, the mush and the lack of glide. I don't know if it's paradox to you, but that seems paradoxical to me. But no, I know exactly what you're talking about in terms of the feel, the tissue feel. But then you say, and also a lack of glide. What's that? How does that manifest?
So, right. So this goes back to that question that Whitney was asking before we got into the definition.
Yeah.
And so that is what I noticed on examination, was that the tissue, when we're palpating and assessing for glide, it's not there. And they're describing stiffness. And my own experience is I feel so much better when I stretch. And so the old adage that if you have hypermobile EDS and you cannot stretch is a complete hogwash, because I've heard from your other episodes, there's a million different types of stretching. You can't lump that into one category. And so they're telling me that they feel stiff, the tissue is not gliding, and it seems to be spongy and uniform in density all the way through. So then you have these conversations with your colleagues and they say, well, you don't know what you're talking about. They're super bendy. They can hyperextend. And I say, well, okay, then what, you always wait around for someone else to do the study. It's like, well, I'm going to prove it, or let's at least look. So with the ultrasound, of course, with Antonio Stecco's study of the sternocleidomastoid, very easy area to study. So he encouraged me to look there. And
so this is, I think, 2014, 2016, something like that, a study where he found changes or differences in sternocleidomastoid fascia in people with and without pain, if I'm remembering that correctly.
Yes, and it was thicker in those with pain.
Yeah.
And so I was certain I was going to see something similar. I just didn't think that it would be so profoundly thicker. So he showed greater than 1.4 centimeters. I found at that it was actually 1.8 for Ehlers-Danlos. So quite a big difference, significantly. And I have elastography, so that measures stiffness of tissue. So you put the probe on for the ultrasound and it'll show you relative stiffness. And it seemed to be pretty uniform in the Ehlers-Danlos population, which I didn't expect to find that. I was pretty open. Like, what are we going to find here? In subjects with neck pain who were not hypermobile, there was a softening in the deep fascia relative to a increased thickening in the muscle, and the muscle stiffening was not uniform. So it was this non-uniform muscle stiffening with a relative softening in the deep fascia that I did not expect to find. I always thought, following everyone's work in the fascial field, that I thought I'd see stiffening in that deep fascia. That must be where it's coming from. And that is always a humbling experience. Well, what do I do with this? Is this contrary to what we believe? Is this even publishable? Do I even want to send this email to Antonio telling him this is what I found?
This is what caught my ear in Montreal. You were coming up with non-intuitive findings around stiffness. You're finding that they're less stiff in people with pain and more uniform in people with EDS. How did that contrast with what you were trying to figure out? You're trying to figure out Whitney's question, like, what are the tissue level differences in hypermobility? Is that correct?
Yes. And then in people with pain too, because I'm not seeing that, right? When they do those elastography questions, they're measuring the stiffness of the muscle. Everyone's paying attention to the muscle, and the muscle is extremely important. It's mostly connective tissue. We have to look at its relationship to that deep fascia.
And under our hands, I mean, I can just imagine or feel what you're describing, the uniformity, the sponginess, you called it, on one hand in the EDS folks, and less uniform, and a bigger difference between muscle and deep fascia on the in-pain non-EDS people. So I can just picture or feel how that would be. And you said that was a surprise to you.
Right. I expected the densification, or that is defined as is an aggregate, a non-functional aggregation of the extracellular matrix content, including what Antonio Stecco studies, the hyaluronan. And so these pathologic non-functional aggregations then are stickier. And so I thought, sure enough, the sticky glue should be stiff. Not necessarily. They're two different properties, gliding and actual stiffness. And that was a real surprise to me. And what I really learned is that we cannot separate muscle from deep fascia. We have to look at, and then superficial fascia. What is that? How is that functioning as a unit? And then what are the additional properties in terms of gliding and even nerve content that might become pathologic over time?
Yeah. Whitney, I'm thinking you had a question that you were pondering. I'm wondering if this is a good time for it.
Yeah, if I can slip in another one before that too.
Sure, yeah. Let's
just
walk us through it.
Yeah, and this is kind of like for personal clarification here too, to some degree, because this is something I have always heard for a long time when I was, trying to understand and grapple with some of the things. Both my mom and her brother had EDS at a pretty significant level. And when we talked about the diagnostic criteria, we were told early on that this sometimes does skip generations. Is that necessarily true that does skip generations in terms of that genetic disposition, or is that not what you have found currently?
It does. So it's autosomal dominant. So this is going to clarify it. It gets technical. So it's autosomal dominant. So meaning if one of the parent has a copy of this, then the likelihood of the children having it is 50%. But just to throw a wrench in this whole concept is that it seems to not be one gene. It seems to be maybe an epigenetic type phenomenon where a group of genes play together. And so it has variable expression.
Yeah.
So that means from one generation to the next, sister to sister, mother to brother, to however you want to look at it, it's going to manifest differently. And it's going to be more severe in one versus the other. And I think, and many of my colleagues really think along the same line, that it is the environment, it's the epigenetics that are really turning on the phenotypic, the manifestation of symptoms. And so it may not be that you don't have it. It may be that maybe it's mild enough that you don't notice.
Well, there's a lot of things that I do notice, the skin quality, the hypermobility, the long limbs and fingers and all those kinds of things, I think do pop up and are characteristic in both myself and my sister. So, but what didn't pop up was the, extreme bruising and the connective tissue damaged so easily. And so we got this safe stuff, if you can look at it that way. That's, not some of the things that we saw, with my mom and her brother. Frequently, but this does, when you were talking about the tissue types with what we feel during palpation, that definitely made a lot of sense in terms of what I experienced in working with her frequently too, with the quality of those tissues. And that kind of gets into what this other question that we were pondering. Till and I had been talking about this about a good bit, that trying to sort of grapple with this issue around densification and the myofascial pain. And I'm curious to hear your thoughts if you think you noticed at least, I think in your study, saying that there was a correlation there, but do you think there is some kind of cause-effect relationship between those? Because we often hear that, like, is that because the densification, because there is pain, or is there densification, or pain because there's densification, et cetera? Do you see any kind of cause-effect relationship there?
So it seems to be, and those are really difficult to prove. So in a separate study that I did across the board of all different patients with myofascial pain, when and I still treat this way. So I will sequence the patient using the Stecco methodology, and then I inject into the 3 different fascial layers as described by the shoulder study. And what they had done was so interesting. They took hypertonic saline, which is an irritant, and they injected it into the superficial fascia, the deep fascia, into the muscle. And then they had their subjects characterize and describe the pain. So I thought, oh boy, this is so interesting. So basically, if I can get the patient to describe the type of pain they're having, then I can inject into that layer with saline. And the saline will wash out those inflammatory mediators that we find in these quote unquote trigger point areas. And it will also serve to manipulate the tissue, much like you would with the finger, but I'm going to do that with saline. And I learned how to do these injections around nerves. We call those hydrodissections of nerves, of entrapped nerves.
Can I pause just a second and ask this before we go on? Because I'm really curious about this. Some of those fascial layers are so thin. How do you get precise with those injections into those specific layers?
Under ultrasound guidance with itty bitty tiny needles. And that I learned from my friend Kentaro Onishi. He likes to inject stem cells through itty bitty tiny needles.
Wow.
And it's for patient comfort. And I was always inspired by that. So I use the tiniest needle possible. And we go into these layers. And yes, it's challenging to see under ultrasound, but yes, you can. With good skills, you can see where you're injecting. And in this study, I found that 75% of myofascial pain, so when I inject into that deep fascia, yes, in combination with other layers, like it might be deep fascia, superficial fascia, deep fascia muscle, depending on the point. But 75% of the pain seems to resolve after I inject that deep fascia in combination with other layers. So it seems like a lot of it is coming from the deep fascia. The superficial fascia was involved in various combinations, 55% of the time. So that means we have to treat that superficial layer, that in-between layer. And then if we talk about only muscle, and this is very controversial statement. When we published this paper, it was extremely difficult. It was so controversial because of the trigger points that are done. So a lot of physicians in my field do a lot of trigger points, and then a lot of physios do the dry needling. And you never want to see anything that comes out against what you're doing. And muscle was only involved muscle alone, because in combination with these other two tissues, yes, 43% of the time you need to treat the muscle. But if you are only treating muscle itself, it's only 5% of the time that you're actually adequately treating patients.
You're saying that was a controversial finding because it went against the narratives that we typically use of muscle being the source of a lot of that nociceptive
Right.
pain. Yeah.
And if you're getting results from injecting those, what is this supposed mechanism of pain management or pain relief from that? What do you suppose is relieving that pain from the injection?
I think it's twofold. I think it's the actual manipulation of the tissue. So if there are glycosaminoglycans, of which hyaluronan is a type, that is causing some kind of mechanical dysfunction, stickiness, then we're opening up that tissue. And just like you would do with your finger gliding, a manipulation of tissue. And then the last part is really washing out any inflammatory mediators that are very, very, very likely present. Even digging through the literature over the last 10 years, already the histologists were calling fibroblasts immune cells. They were primary sentinel immune cells. And it's just so interesting that I was talking to one of my colleagues yesterday. Why isn't it that us as physicians, why have we not been introduced to this? Why is what I do, recognizing Ehlers-Danlos as this real manifestation of inflammatory, fascial inflammatory changes? Why is that so avant-garde? Why am I so fringe? When 10 years ago, the histologists already started identifying these concepts.
That inflammation was involved in those kind of locally sensitive or painful spots, and that changing inflammation could actually change that experience as well. Or that maybe that was a mechanism of what you were doing. Now, I want to make sure we get the right reference to what that study you're just describing. Is the study you just described with the reduction in pain, is that a published study? Is that something we can reference?
It's open access, and I'll send you a link.
Awesome, we'll
afterwards.
get that.
Yeah,
that's fascinating.
Yeah.
And then those numbers you gave, 75% of pain related to the deep fascia, that was a percentage of patients who reported an improvement in pain, I presume.
They all did immediately after injection. That's how I measured, was this the tissue? Was this the correct tissue layer to treat? And then I do a pain pressure threshold. Is that the same, or did we improve?
Okay, great. I look forward to reading that through. That's fascinating.
Yeah, that paper is different. That one I did. So traditionally in the Ehlers-Danlos population, we'll do a headache protocol Botox injection, which horrified me. And there are case reports as well as anecdotally of patients who became destabilized and ended up having cranial cervical fusion. That this is not to scare people. They're very rare. Very rare. You know, we had a discussion in my EDS Echo group. That's the professional group that meets once a month. We meet practitioners around the world, and it's hosted by the Ehlers-Danlos Society. And we've even had conversations about muscle relaxants in this group. And yes, there are horror stories, and there are few and far between. The important thing to know is that every Ehlers-Danlos patient is an N of 1. You can't make sweeping judgments as a whole. Like, you do not do stretching. You do not do deep tissue. It's right. No, that is your N of 1, and you move slowly. That's the principle when treating these patients. Just move slowly, get to know them, get to know their tissue before you start hacking away, before you start throwing tons of drugs at them. Get to know the person, get to know the tissue, get to know how they respond. And so in that study, I noticed that they all had a very certain type of patterning, a cervical dystonia, not severe. And to your audience who doesn't know what that means, it's a patterning that happens into a neck, a twisting, and they're kind of locked there neurologically. And so there is a Botox protocol for cervical dystonia, and I partnered up with one of my colleagues who is an expert in cervical dystonia, and we sequenced the patients fascially, and then we identified using standard cervical dystonia protocol that most neurologists use, and lo and behold, they all kind of lined up. The fascial line dysfunction with the dystonia protocol, how you would choose which muscles based on rotation. And these few patients that I followed improved, and the thickness of that sternocleidomastoid also decreased, and their pain.
The only intervention was the Botox injection. Is that right?
Right. And into muscle.
Very interesting. Into muscle.
Yeah.
Yeah. So just my simple layman's understanding, the Botox essentially relaxes the muscle at a very deep, it eliminates the motor neuron input or the effect of the motor neuron. So you have complete relaxation of the muscle. Is that the primary mechanism, you think, that's
yes,
causing that?
And it's low dose. So I'm not using that full large dose. I'm just using low dose so that we provide a balance to the system.
Okay.
And then why does it keep recurring? Well, I really, I'm a workaholic. I can't stop working, and I love what I do. So I took a course from Mary Mastery so that I wouldn't keep working. Take a course to occupy my schedule. And it was one of the best courses I've ever taken. And she is a pediatric physiotherapist, and she started talking about patternings that she's noticed in these children. And I started paying attention to some of these patternings in my patients. And I started to realize, boy, I think Ehlers-Danlos is neurodevelopmental. They have very similar patterns to how they're firing the muscles. And with this population, it's really about maintenance and staying ahead. It's not going to be about curative, but how do we help you with a maintenance program to live the best life possible, which I think can be a wonderful life. You just have to figure out how to stay on top of everything.
What are some of the highlights of a maintenance program, or especially as relates to manual therapy? Does manual therapy belong in that picture? And if so, how?
Absolutely. One of the things that has come to the forefront, especially with the leaders in the EDS Society, is the neurodevelopmental neurodivergence. There is a high rate of that in Ehlers-Danlos. And after that pediatric course, I started paying attention, because neurodevelopmental issues and neurodivergence, they're classified as the same thing. And I started paying attention, And what I find, and this is just a supposition, which I'm in the process of writing a book because you can't publish this kind of stuff. It cannot be proven. And one of the things that I feel strongly about is that this starts first as a neurodivergence. So meaning we're born as autistics, we're born with ADHD, we're born with our sensory issues, and now we have to fit into this world. And maybe we know that neurodivergence has strong inheritance. So maybe our parents are pretty traumatized and they can't provide for us skill sets and tools. And now we're set free in this world. And from a very early age, we're making adaptations. And that nervous system is going crazy. And where it's going to show up first is that superficial fascia, that autonomic nervous system. So absolutely manual therapy has a huge role, because if we want to start to affect upstream where we think things are coming from, that touch is so crucial. That therapeutic relationship that I know you both talk about so much is absolutely crucial. And if we don't have that, we don't even have a starting point to help patients.
Wonderful. And the touch being a primary channel of experience in that realm. Saying in that process, what a fascinating idea, that process of becoming, of development being a process of becoming neurotypical, you could say, or developing out of a state that's more divergent. And the actual interaction we have through touch could be a part of that for all of us. Did I get that right?
Yes. And I can speak as my own experience as a neurodivergent person with autism. Human connection is craved, but so difficult to access. And it's through these therapeutic relationships that we can start to tell that person, that body, that brain, that spirit, here is a person who can be with you.
Nice. That's what our hands say when we're doing.
Yeah.
We're listening to our clients, when we're sensing what's going on, we're getting the feedback from both their tissues and their awareness. Essentially, that's what our hands are saying. We can be with you. This is good.
Yeah. I want to ask to backtrack for a moment too, and back to when you were talking about some of the things that may be happening or occurring. And again, not to sort of scare people or over concern them, but a lot of manual therapists who might have clients coming to them with EDS, this is frequently going to be their first exposure to it. And I was curious if you've got things that you would recommend in particular that people really think about or be particularly cautious about when somebody comes in and just, let's say, puts on a health history form, I have EDS. What kinds of things should they be thinking about there or being careful of in their treatment with them?
Right. Great question. So, and I've been there. I've been there on the airing portion.
Yeah.
So they will get huge autonomic dysfunction and response. So what is that? That is the nervous system going crazy. They will report fevers, chills, catatonia. I didn't wake up for 12 hours. That's always a great phone call. My heart is exploding when I hear that.
No, you're saying this is after a treatment, or when does this
after
the
experience?
Oh, really?
Yeah.
Interesting.
Oh. Yeah. And so the biggest one is fevers, and that will be your biggest clue is when the client says, "Oh, I had fevers," and maybe the temperature goes up, but it may not. But it's in the body; it's subjective. They feel it. That's a huge clue that this might be someone with pathologic hypermobility that you're working with.
And so this is just because the autonomic nervous system is just kind of getting stirred up, so to speak. Is that kind of what's doing this?
Yes.
Interesting.
And I think there's what I see in this population is there's a much higher sensitivity to interoception and exteroception. So these nerves are very sensitive. And if you're going to bombard them and you're going to come in, I train with osteopaths. So if you come in with your hubris and I'm going to change this tissue and I'm going to heal you, I'm going to fix you, I will tell you personally, when someone lays hands on me and they come into the room with that, my body is screaming. I'm about to run out that door.
Uh-huh.
And I always joke that I like novice practitioners, because novice practitioners come in like, I don't know. And I love that, because my nervous system senses safety. My nervous system senses this is not going to be a person who's going to hash at my tissue and tame it, because my tissue is not tameable.
Yeah.
How about the fact
reference that? Tell me,
go ahead.
One more thing real quick. You referenced a couple terms there. Till and I did talk about this in some previous episodes, but in case people missed that, can you just briefly go over what you mentioned about interoception and exteroception for people to recognize what that means in terms of what someone might express in a session environment?
Right. So I always love this. This is what I say, oh, you have EDS when I'm down at the foot or I'm injecting to the foot, and they say, oh, I feel that in my right shoulder. Well, oh man, I should check you for EDS. So that's the interoception, to be able to feel what's happening within that body. And then the exteroception is that sensory processing stuff, the light coming in, the colors, that those papers are not perfectly organized. And so we see a high rate of Ehlers-Danlos in the ADHD population, in the autistic population, and then vice versa. We see a lot of ADHD and autism in the hypermobile spectrum disorders, Ehlers-Danlos disorders, and a large part of the existence and experience of these people are this huge amount of interoception and exteroception. And we often like to mislabel and type autistics as not having empathy. It's huge amounts of empathy. It's just we don't actually understand why you're having that emotion. So I can see, oh, you're angry. I said something wrong. I have no idea why you're angry. And then I'll need some explanation.
Interesting. Yeah.
That's a really helpful distinction too. Yeah. I just want to flag Ruth Werner, who actually, I told her that we were speaking. She writes a pathology column for Massage and Bodywork, etc. She actually had that question about dysautonomia and EDS. They seem to be co-occurring, and she's wondering about the mechanism. I think you just described that. You're talking about the process of development being a somatic one that includes both the tissue qualities and the relational interactions and the nervous system regulation, all as an integrated whole. I think that's what you're describing here for us.
Right. And then in terms of if we get a little bit more nitty gritty into like histopathology, fibroblasts have released neuropeptides that speak with surrounding nerves, and the nerves and the fibroblasts release neuropeptides that speak with the immune cells in the area, macrophages, mast cells, and they're all in crosstalk in these areas surrounding vessels. And so now you get a systemic effect, and you can't tease out one over the other.
Hopefully a systemic effect that could go either way. It could be calming or it could be irritating, accelerating. But their hope is we find a way to do our hands-on work that leverages those salutary systemic effects from the local occurrences that are probably happening. Okay, here's another great question from Ruth. She said, this is just a quote, from my little pointy-headed perspective, she says, it seems like diagnoses of EDS are more common than they used to be. Is this because of more sensitive diagnostic tools or something happening to us genetically, or am I wrong? She says.
All of the above. All of the above. So I would say first to tackle that question is EDS Society. We will meet, every so often and reassess how we're categorizing patients. And then there's a strong need for patient-centric diagnoses. What is it that this patient needs? I'll get into arguments with people, and they don't meet the diagnostic criteria. Okay, but what does this person need? Because there's a lot of gray area in diagnoses. I can make something fit into that box, or I can make it not fit in that box, depending on how I frame it. And so what is it that this person needs? Does this person need reassurance that, boy, this is not the source of my issue? Or does this patient in front of me need this diagnosis so they can all begin to understand the world around them and move forward in their healing journey? So part of our discussions in the EDS Echo is, how do we make our diagnoses and care patient-centric? And so then you'll see an increase. There's also increase in awareness with advocacy. So me coming on here, previously in the past, I was not comfortable letting people publicly know that I have hypermobile Ehlers-Danlos because of all the stigma. So does that mean you can't work? You're going to call off? What does that mean? Right. And I didn't feel that I was representative of the population because my patients are quite ill and they have a lot of functional difficulties. And it wasn't until knowing that I had comorbid autism and how that, or co-occurring autism, the preferred language now, that I started to really see how that overshadowed and framed my experience of having Ehlers-Danlos. You know, I've moved into a different direction from many of my patients. Some of them come in like this too, is I'm not interested in a diagnosis. From a very young age, I had doctors telling me I was crazy, and I decided that I will just figure it out myself. And how is it relevant that I wake up in pain every day? I wake up in pain every day. I'm going to go work. And so I know that my experience is very different from many of the patients who come in needing a framework to understand their world. But once I had this knowledge of my autistic experience as a person with Ehlers-Danlos, living with co-occurring autism, I started to realize that I had a very valid advocacy point of view as well, and that there are many people living like I do who may be lost in their understanding of the world, who cannot even begin to conceptualize what it is to deal with their chronic pain issues if their relationships are so confusing. And so that was one of the impetus for me coming out and saying, okay, I have this condition too. And people who have co-occurring autism with hypermobile EDS have an actually larger burden of disease, meaning we have more of that dysautonomia. We have more of that immune dysfunction. We have tons of allergies. I can't eat anything. Sometimes if I look at that bread, my stomach starts hurting. And so that's the impetus, is that more and more of us are coming out, speaking up in the public forum. And then the last piece is the environmental piece. I think we live in a cesspool. We are destroying our environment. The foods we eat are horrendous. And if we're putting plastic particles into our environment and into our foods from a very young age, what does that do phenotypically if you're predisposed to this stuff? We were watching a news article segment, and my 9-year-old was disgusted. The 9-year-old knew to be disgusted by what we're doing to our environment. And across the board from my colleagues, we seem to all feel the same, that it's environmental.
It's such there's so much pain in the background, I think, for all of us about what the state of the physical world and the environmental world, that it's hard to separate that out. And then there's the direct medical and developmental effects. And I just want to take a second and thank you, though, for sharing your journey and your story, and just it's added another level of my appreciation of your work, your inquiry into both what works for you, but then also trying to understand the mechanisms in a way that we can all learn from that and influence what we're doing with people with hypermobility issues, EDS, but also other clients as well. So there's a very human element to what you're describing.
Absolutely. I think you have such a unique perspective about that lets people really recognize and see so much more, looking at it from both the clinician and the experiencer, both. I think that's a tremendous gift that you have given everybody. So thank you again so much for that.
Yeah, I just want to thank you for the work you do. And this platform you have is advocacy, and it's phenomenal.
Thank you for
Mhm.
taking the time.
Yeah.
Any other thoughts you want to leave us with, Dr. Wang? We'll call it a day.
Just go slow. When you
Yeah.
meet your Ehlers-Danlos patient, go slow and form that connection, because that connection is just a lifeline for them.
That is a key thought. And I loved what you said about the beginning therapist sometimes being more receptive to that.
Yeah, that's interesting. Yeah.
That's great.
Mhm.
All right. What do you think, Whitney? Should we close it up?
I think so. Yeah, that was a fascinating dive into this, and we may, hopefully, if that's okay, call you back to explore some of these things in greater detail at some point later down the road as well, because it certainly has opened up a lot of questions and other things for me to think about along these lines.
I have a little mind map here with bubbles headed off in every direction and more little avenues to explore. So thank you for that expansive process here.
Yeah.
Okay, our closing sponsor today, Handspring Publishing. When I was looking for a publisher for a book that I wanted to write, I was fortunate enough to have ended up with two offers, one from a large international media conglomerate and the other from Handspring, which at that time was just a small publisher in Scotland run by 4 people with a love of great books and our field. To this day, I'm glad I chose to go with Handspring, as not only did they help me make the books I wanted to share with you, the Advanced Myofascial Technique series, but their catalog has emerged as one of the leading collections of professional level books, written especially for body workers, movement teachers, and all professionals who use movement or touch to help patients achieve wellness.
And Handspring was recently joined with Jessica Kingsley Publishers' Integrative Health Singing Dragon imprint, where their amazing impact does continue. So head on over to their website at handspringpublishing.com to check out their list of titles, and be sure to use the code TTP at checkout for a discount. And thank you again, Handspring, for supporting the podcast. And we do thank all of our sponsors. You can stop by our sites for show notes, transcripts, and any other kind of extras over there. You can find that on my site at academyofclinicalmassage.com. And Till, where can people find that on yours?
Advanced-trainings.com. If there are questions or things you want to hear us talk about, email us at info@thethinkingpractitioner. Look for us on social media under our names. My name remains Till Luca. Whitney, yours?
And you can find me over there on my name as well through Whitney Lowe. And you can, if you will, rate us on Apple Podcasts, as it does help other people find the show. That's very helpful for us. And you can, of course, hear us on Spotify, Stitcher, Google Podcasts, or wherever else you happen to listen. So please do share the word and tell a friend. And thank you again, Dr. Wang, so much for being with us today. This was a delightful conversation.
Great. And Dr. Wang, where can people find out more about you, your work? What would you like to direct them towards?
Yeah, absolutely. So with the brain cell seminars, we are hosting hands-on courses, interdisciplinary, and people can find us there too. And I'm co-hosting the courses with Claire Frank, physio. And if you go to the website, which I'll share with you after the podcast, they can.
We'll make sure that's in the show notes. Yeah.
Yeah, they can take a look there.
Okay. Well, thanks again. Thanks again, Whitney. Thanks again for Dr. Wang.
Yeah. All right.